Hi, I'm Dr. Allison Smith, head of the clinical team here at Precision Analytical, creators of the Dutch test. Join me as we walk through a female Dutch Plus report. Here's our Dutch Plus report with hormone testing summary page in the middle. We're going to start here. On the summary page in the upper right corner, let's get oriented. We can see this test is for a 49-year-old female. They collected their samples on cycle days 20 and 21. And we know this because the last menstrual period was April 23rd, and the samples were collected on the evening of the 12th of May and the morning of the 13th of May. So cycle days 20 and 21 should be mid-luteal if this patient had a 28-day cycle. And this patient is perimenopausal with irregular cycles, so we're kind of guessing here. This is what we're hoping the report will tell us. Estradiol is within the normal luteal range, represented by the green arc in the dial. That looks good for, maybe catching a luteal sample here. The postmenopausal range is in purple, just to put it in perspective. So the estradiol is normal. Progesterone serum equivalent, though, is very low, suggesting the patient maybe has not ovulated or has had an insufficient luteal progesterone output, or maybe we've caught her in the wrong time of the cycle. The progesterone reported on page 1 is actually a serum equivalent value calculated from the urinary alpha and beta pregnane dial reported on pages 2 and 3, and I'll show you that when we get there. Next, we find phase 1 estrogen metabolism strongly favoring the higher risk pathways, the 16-hydroxy and the 4-hydroxy E1, with those carets pulled all the way over to the left in the slider bars. And to make matters worse, phase 2 COMT methylation activity is also very low. Next, we find DHEA and testosterone in the androgen section there. Both are falling within their normal green ranges for a cycling female, which is good. But when we look at the androgen metabolism, we notice right away that the 5-alpha androstenediol dial is elevated, and the high 5-alpha metabolism DHEA slider there shows us that this is a pretty androgenic lab presentation, right? And it's not because the androgen production is high. DHEA and testosterone look very normal. It really is a metabolic issue. In the cortisol section, we find the free cortisol graph shows us bottom edge waking cortisol, an under-responsive cortisol awakening response, and a high midnight cortisol level. So I imagine this individual has some trouble with their sleep. Overall, when we look at the free cortisol added up over the day's samples, it's pretty low. But we're really glad we did a Dutch test, because when we assess the metabolized cortisol total, it's high. And that tells us that total cortisol production over the course of that whole day is actually really elevated. And the high cortisol clearance rate tells us that cortisol is breaking down very quickly in the tissues, and the body is working really hard to control access to free cortisol in the face of high cortisol production. And this body is really trying hard to adapt to whatever that stress is. So in the oats alerts section, which is a new section on the summary page as well, we can see B12 and B6 deficiencies are noted, a gut etiology perhaps, and even neuroinflammation, low melatonin. Probably some of this is influencing cortisol and estrogen metabolism. And all of this we're able to glean from the summary page. So we really just found out maybe everything we need to know to get started with a treatment plan. And that really is the power of this new Dutch Plus summary page. Well, let's go further to see if there's anything else we can dig up in the next section, which is the sex hormone panel. Now, page 2 visually displays pathway flows for the sex hormones and androgens. Page 3 is where you'll find that table list of findings. So we're going to focus on the pathway flows on page 2. In the upper right corner, we find the progesterone metabolites are both lower than luteal and even falling into the menopausal ranges. And these are the progesterone metabolites I alluded to that are used to calculate the progesterone serum equivalent on page 1. We like to use the serum equivalent because it gives you an idea of what you might have drawn in the serum if you would have tested on the same day, blood on the same day as the urine. And it is the alpha pregnane dial in particular that informs us about progesterone's potential neurosteroid activity in the brain at GABA receptors. So here we can see this patient actually has a pretty high 5-alpha metabolism of progesterone, and that tells us about this person has more propensity for formation of those GABA A binding metabolites, right? She may respond to lower doses of progesterone if we were giving it orally. Parent estrogens in this case are sitting within their ranges, but on the higher side compared to progesterone metabolites, which are low for a cycling female. This is consistent with perimenopausal, irregular, or even anovulatory cycling. We use the population sliders to assess phase 1 estrogen metabolism. And here we see that strong preference for the 16-hydroxy and 4-hydroxys when each are compared to the 2-hydroxy E1 level. And this represents a higher risk metabolic profile. She is perimenopausal. She might be thinking about hormone therapy, and we want to be able to talk to her about her phase 1 metabolism and be protective at the same time as treating with hormones down the road. The methylation activity population slider informs us about phase 2 COMT activity. So for this patient, COMT methylation activity is pretty low. So we're comparing 2-methoxy-E1 to 2-hydroxy-E1 for that calculation. And remember, all of the calculated ratios and their ranges that we use to generate the population sliders are on page 3 of the report in the sex hormones list of findings in the table. Let's look at the total DHEA. Here's total DHEA production. This is the sum of DHEA sulfate, androsterone, and etiocholanolone. Here we see that the DHEA sulfate is relatively low compared to its downstream tissue metabolite, androsterone. And this is really a common finding with inflammation and insulin resistance. So that's already something that we're starting to think about with this test. The 5-alpha metabolism population slider for DHEA confirms that DHEA metabolism favors the 5-alpha. Testosterone's within the normal range for a cycling female, but again, we're glad we did the Dutch because we see 5-alpha androstenediol is high, and that confirms that she has a lot of 5-alpha activity leading through to DHT or dihydrotestosterone formation in the tissues, and that could be an underlying driver of acne or hirsutism, irritability and perimenopause, and even scalp hair loss. All things to think about. Now let's move into the adrenal panel next. Page 4 is the visual representation of the cortisol data. That now comes before the table list of findings on page 5. Here we see free cortisol and free cortisone diurnal patterns are similarly shaped. They have low normal waking free cortisol and cortisone, right? Just hugging the very bottom end of the range. We see an under-responsive CAR, not even making it up into the normal range in 30 minutes. And at midnight, we see an elevation in cortisol and cortisone that tells us that there may be some nighttime stressors at play. So maybe this could be a sign of blood sugar issues or sleep apnea. Maybe she's waking up because she has chronic insomnia or circadian rhythm dysfunction. The daytime points added together tell us that overall there's a low free cortisol during the day, but we see that uptick of cortisol at night. We get concerned a little bit about nighttime stressors. So keeping that in our mind as we go into the metabolites of cortisol, low daytime cortisol, elevated cortisol metabolites informs us that cortisol production and clearance is actually really quite high for this person. And maybe a lot of it's happening at night. Those low free cortisols are actually part of an adapted stress state. This is an adrenal stress picture. So we should be thinking about exactly what stressors are driving it. Common causes of high cortisol clearance rate are insulin resistance and inflammation, but there are a whole laundry list of other possible drivers you can find in our interpretation guide. The systemic preference population slider represents the relative balance between cortisol metabolites and cortisone metabolites. These are mostly formed in the liver and adipose tissues. It's normal in this case, a bit on the cortisone side, but a shift to the right to cortisol or THF represents acute stressors and that short burst cortisol activation, while a shift to the left to cortisone or THE represents that chronic stress and body adaptation to long-term high cortisol exposure. And she does have a tick towards the cortisone long-term exposure side. Melatonin level comes from the waking sample, and all the waking samples contain the hormones that were produced, circulated, and excreted during the night while the patient slept. So for melatonin, this should be the time of highest production. We see this patient has a pretty low overnight melatonin production. I wonder if that's because of that elevated midnight cortisol. And finally, the organic acids bring up the tail end of the report. We already know what we're going to find. We saw it on the summary page, already told us about her deficiencies. B12 and B6. We saw high indicin suggests dysbiosis or maldigestion, and HVA and VMA would inform us about sympathetic nervous system activation and neurotransmitter clearance issues if they were abnormal. They're not. But she does have some markers of oxidative stress and inflammation. These help you zero in on causes of cortisol and estrogen detox abnormalities. Her high quinolinate suggests that she has some neuroinflammation, possibly driving the elevated cortisols. We saw the melatonin in context with the diurnal cortisol and adrenal page 4. That's really where it's most helpful to put that information together with the cortisols, but you'll also find it here on page 6. Don't forget to use our new About Your Results comments section. It is full of patient-specific comments that are designed to help make your life a lot easier. With these, you can quickly identify and treat abnormals, any underlying hormone issues. We call this section the Dutch Dozen, and these comments really help you interpret the findings, particularly on the summary page. We think you will love using the Dutch Dozen. It's distilled, it's simplified. You can feel confident basing your assessment on these 12 key concepts. And you want to get to the fun part faster. You want to design the treatment plan. The Advanced Insights section is full of comments that help you dig even deeper to identify more advanced patterns if they exist. These deeper level concepts that may not be pertinent in every single case, but those you should consider for some, like 5-alpha metabolism of progesterone and cortisol, abnormal organic acids relationships to androgens and estrogen imbalances if they exist, and cortisol-cortisone balance. They're all covered in this section, and similar to the Dutch Dozen, they're also grouped by the hormone story to which they belong: estrogens, androgens, and cortisol. So really easy to follow. The summary page of the Dutch Plus really gives you that detailed look at stress's impact on cortisol and DHEA, sex hormone metabolism's impact on hormone systems, and it really helps you drill in on the etiological issues like dysbiosis and nutritional deficiencies that may be at the root, all on the summary page, simply, comprehensively. And our goal with this new version of the report is to help get you from summary page to a comprehensive treatment plan in just a few minutes. Don't forget to use your provider resources that we've made. The Dutch Interpretive Guide is an incredible resource that walks you through collection to interpretation for Dutch reports on cycling and postmenopausal females, and also with a section on males. There's valuable information in there on common patterns and even some treatment pearls. The mini guides dive into condition specifics, and the treatment guide gives you a multitude of ideas for treating highs, lows, and patterns found on a Dutch test. As a provider, you have access to all of our clinical resources, courses, and of course, consults. Thank you for walking through a female Dutch Plus. I hope you feel ready to use this with your next patient.